pre-recorded the session. I hope that this week we don't get the glitches that confounded last week's presentation from Zoom. Sasha assures me that Zoom apologized for all the problems that occurred last week. So hopefully this week we will have a flawless performance. And I'm going to hand over back now to Sasha to start our pre-recording on common arterial trunk. So this is what we are going to discuss this afternoon. An arterial trunk leaves the base of the heart through a common arterial valve and supplies directly the aortic, pulmonary, and coronary arterial pathways. I hope I can persuade you to call this a common arterial trunk. And what I'm going to emphasize is that the phenotypic feature is the commonality of the ventriculo-arterial junction. And I hope that will become clear to you as we proceed through this classroom. So this is what we are talking about. This is one of the lovely pictures from Diane Spicer. I'm particularly dependent today on the images provided by Diane. So this is a typical example of common arterial trunk. There you can see the common ventriculo-arterial junction, and leaving the base of the ventricular mass, we have the common channel that supplies directly the systemic arteries, the pulmonary arteries, and the coronary arteries. Now, I am sure that there are many of you who still think of this as persistent truncus arteriosus, or simply truncus arteriosus. But is that really justified? Because it all depends on what we mean by the embryonic truncus. And if we can define the truncus in an agreed fashion, is it then failure to septate this component of the developing heart that is responsible for the common ventriculo-arterial junction? So let's explore that. And if we go back, we find that it was Theodore Kramer in 1942 who introduced the notion that we could consider the developing outflow tract in terms of the truncus as opposed to the conus. This is his paper, as I say, published in 1942, a seminal work. And he produced the paper because, as you see here, he was worried that the terms employed by previous workers had been so discrepant that they were unable to cope. What he says here, the rapidly changing shapes and locations in which the structures themselves are found at different stages of development. And what he says remains true. And here is what he came up with. He said that the partition formed in what he called the truncus arteriosus meets the more proximal part of the outflow tract, which he called the conoventricular portion, so that the right ventricle ejected its blood into the pulmonary circulation, the left ventricular output reached the aorta. But this is the key, because he said the septal system divides the truncus arteriosus into the aorta and the pulmonary arteries. So what he is talking about as the truncus is the component of the outflow tract that becomes the intrapericardial arterial trunks. Now, to me, the problem with the approach taken by Kramer is that it ignores totally the contribution that are made to the outflow tracts by the arterial roots. So let me illustrate the importance of that by sharing with you the situation in the postnatal heart. So this is an oblique subcostal cut through a normal heart, and I'm showing you here the outflow tract from the right ventricle. And as you all know, the right ventricle has a long, freestanding muscular sleeve that we call the infundibulum. And the infundibulum supports the pulmonary root. And the pulmonary root occupies the middle part of the right ventricular outflow tract. At the sinutubular junction, it becomes the pulmonary trunk. And then the pulmonary trunk extends to the margins of the pericardial cavity, where it then divides into the right and left pulmonary arteries. If we then look at the outflow tract of the left ventricle, we can describe that in exactly the same fashion. So there is a subvalvular compartment, not nearly as long as the infundibulum of the right ventricle, because posterior-inferiorly in the left ventricle, we find fibrous continuity between the leaflets of the aortic and mitral valves. But nonetheless, we have a ventricular outlet, and that supports the leaflets of the aortic root. And again, this occupies the middle part of the left ventricular outflow tract at the sinutubular junction. It gives rise to the intrapericardial component of the ascending aorta. So if we analyze the components of the postnatal outflow tracts, within the pericardium, we have these three parts: the subvalvular outlets, the arterial roots, the intrapericardial arterial trunks, and then at the margins of the pericardium, the intrapericardial pathways give rise to the extrapericardial arterial pathways. We must then ask the question, is it possible to consider development also in this tripartite fashion, and in that way provide a better way to describe the development of these intrapericardial arterial pathways? And our investigations over the last 10 or 12 years show that this is indeed possible. This comes from a study I did together with Alexander Cesarov and his colleagues in Amsterdam, Anton Moerman, Wout Lammers, who was in Amsterdam at the time, and we looked at the development of the human heart. And this is the early stage of human development. Those of you who have been watching previous classrooms know that we grade human development in terms of Carnegie stages. This is Carnegie stage 13. It's about 5 weeks of normal human development. And everything that you see here in silver is showing you myocardium. And at the early stage, the entirety of the outflow tract is myocardial, and we can recognize that it has proximal, intermediate, and distal parts. Then at the margins of the pericardial cavity, at this early stage, the outflow tract gives rise to the aortic sac being a manifold within the pharyngeal mesenchyme, and that gives rise to the arteries of the pharyngeal arches. So we can begin to analyze development in tripartite fashion. We know from our ongoing work in the mouse heart that it is the same there. This is a very nice reconstruction made by my colleague from Newcastle, Simon Bamforth. And there you see the extrapericardial components, the pharyngeal arch arteries that are arising from the aortic sac. And within the outflow tract, we have an undivided distal component. And then we see the outflow tract cushions or ridges, which are spiraling through the intermediate and proximal parts. And if we then look at the way that the outflow tract becomes separated into its aortic and pulmonary components, we see that the distal part of the outflow tract, there in this episcopic image, you see the margins of the pericardial cavity. The distal part of the outflow tract, which will become the intrapericardial aorta, the intrapericardial pulmonary trunk, is divided by a protrusion that grows from the back wall of the aortic sac. It enters the pericardial cavity, dividing the distal outflow tract, as you see, into the intrapericardial components. And there, within the intermediate component of the outflow tract, extending proximally, we see the outflow tract cushions or ridges. And at this early stage, we find an aortopulmonary foramen. And I will return to that aortopulmonary foramen towards the end of my presentation today. So it is the aortopulmonary septum, the protrusion from the dorsal wall of the aortic sac, that divides the distal part of the outflow tract. And by tracing development, we can see that that aortopulmonary septum separates the intrapericardial component of the aorta from the intrapericardial part of the pulmonary trunk, and they are now forming the distal components of the outflow tract. The cushions then separate the intermediate and the proximal parts. And if we take a cross-section through the intermediate part of the outflow tract at this stage, we can then see very nicely that it is the fusion of these distal part of the cushions that has separated this intermediate part of the outflow tract that is retaining its pericardial covering into the developing aortic and pulmonary roots. And then if we look more proximally still, we find that although the intermediate part of the outflow tract is now separated to form the aortic root and the pulmonary root, the cushions or the ridges themselves have yet to fuse more proximally. We then know, nonetheless, that as development proceeds, these proximal parts of the cushions will themselves fuse together. They will build a shelf in the roof of the right ventricle that will separate the aortic root from the cavity of the right ventricle, and then with ongoing development subsequent to closure of the interventricular foramen, that shelf will become the muscularizing infundibulum, and it will then be separated by the extracavitary tissue plane from the aortic root, giving us the freestanding muscular infundibular sleeve. So if I summarize what we know of normal development, we now know that the extrapericardial pathways develop from those branches of the aortic sac which percolate through the pharyngeal mesenchyme and reach the dorsal aorta. The distal outflow tract, which was described by Kramer as the truncus, becomes the intrapericardial arterial trunks. And then the conus, the proximal part, becomes the ventricular outflow tract. And what I've shown you now, I hope, is that the arterial roots develop within the intermediate part of the outflow tract. And this is why it is so important to take this tripartite approach to development, because only then can we take note of what is happening to the arterial roots. Now, why is that important? It's important because we need to know which components of these developing structures are deficient so as to produce a common arterial trunk. And is it justified to describe this entity as a persistent truncus? So we now are fortunate because we have genetically perturbed mice that we know have common arterial trunk. And these mice, the TBX1 null mice, the TBX1 gene has been knocked out. All of these mice develop common arterial trunk. So we can trace what happens as development proceeds. And so I'm showing you an episcopic image from such a TBX1 null mouse at embryonic day 12.5. And had development proceeded normally, by this stage, the intrapericardial trunks themselves would have separated into the aorta and the pulmonary trunk. But what you see in the null mouse is that, in fact, the distal outflow tract has remained as a common entity. And then, as we look through the intermediate and the proximal part of the developing outflow tract, we see that the cushions themselves has failed to fuse. We can take a cross-section through the intermediate part of the outflow tract. I showed you a comparable section just a few moments ago, and I showed you that by embryonic day 12.5 in the normal mouse, this intermediate part of the outflow tract had separated into the aortic and the pulmonary roots because these distal cushions themselves had fused together to separate the arterial roots. So here is a cut across the intermediate part of the outflow tract in the TBX1 null mouse. And what you can clearly see is that the distal cushions have failed to fuse. And in fact, the evidence has existed for quite some time that it is failure of fusion of the outflow tracts that is responsible for producing common arterial trunk. And Lodewijk van Meerop, the pediatric cardiologist, embryologist who worked at the University of Florida in Gainesville as long ago as 1978, in an elegant study using caisson dogs, showed that it was failure fusion of the outflow cushions that produced common arterial trunk. And what I've already shown you is that it is the septum of the truncus that separates the intrapericardial components of the aorta and the pulmonary trunk. And then, in fact, we know that when we look at other mice in which, by perturbing them, we produce common arterial trunk, we've achieved that by perturbing the furin enzyme, we can, in both of these instances, produce common arterial trunk. There is the common valve guarding a common ventriculo-arterial junction. But what we are showing you here is that the septum that divides the distal parts of the outflow tracts, rather, the truncus septum, can be very well formed even when we have a common ventriculo-arterial junction. And to your left hand, you see the situation where we have a balanced arrangement between the aortic and pulmonary components of the distal outflow tract. I'm going to come back to this as we discuss the phenotypic variation within common arterial trunk. To your right hand, you see the situation in which the aortic arch itself is interrupted. There is a pulmonary dominant form with persistence of the arterial duct, and the aorta itself is hypoplastic. So what we can now say, based on our knowledge of genetically perturbed mice, it is separation of the intermediate and proximal components of the outflow tract that is responsible for producing common arterial trunk. And indeed, the intrapericardial components, the distal part of the outflow tracts, can be separated in the setting of common arterial trunk. I'm going to show you how, on occasion, they can in fact be separated in their entirety with common ventriculo-arterial junction. So if we were going to use the study of Kramer to determine how best to describe this entity, then arguably we should be calling it a persistent conus rather than a persistent truncus. But I think it's much better simply to describe it as common arterial trunk. And what I'm going to now show you is the variable features we see in postnatal life in individuals who are born with this entity because there has been complete failure of fusion, those cushions or ridges which normally separate the intermediate and proximal parts of the outflow tract into the aortic and pulmonary channels. Now, what I'm going to concentrate on for the larger part is the interventricular communication, the channel between the ventricles. But what I'm going to show you is that part of this channel is also positioned between the arterial trunks. I'm going to share with you the notion that perhaps this is a ventriculo-arterial septal defect. Having done that, I'm going to look at the way the trunk can be committed to the ventricular mass. I'll discuss with you the variations that we find in the arrangement of the truncal valve, And then I'll concentrate on perhaps what's the commonest way of describing the phenotypic variation we find in the setting of common arterial trunk, the arrangement of the systemic and the pulmonary arterial pathways. And remember, we now know that this depends entirely on what happens to the changes in the distal part of the developing outflow tract. I'll discuss with you the variations in the origins of coronary arteries. I'll make reference to the sidedness of the aortic arch, and then I'll finish by discussing with you the significance of patency of the arterial duct. So many things to discuss in the setting of these lesions which have in common the commonality of the ventriculo-arterial junction. And it is that feature I'd like to start off considering in the setting of the interventricular communication. Because what I'm going to show you is that when we have this common ventriculo-arterial junction, we have in fact a ventriculo-arterial septal defect. And what I'd like to do is to compare the situation that we find in the setting of a common atrioventricular junction. And as you are all aware, when we have a common atrioventricular junction, almost always we also have an atrioventricular septal defect. So let's look what happens when we have atrioventricular septal defect. Now, I discussed this with you at length when we considered the variations to be found in atrioventricular septal defect with common atrioventricular junction. And I'm showing you here three basic arrangements, all with the same common atrioventricular junction, the same atrioventricular septal defect. And what I showed you in the classroom, considering this lesion, is that the phenotypic variation all depends on the relationship of the bridging leaflets of the common atrioventricular valve. So let's start by taking the commonest situation in which the bridging leaflets of the common atrioventricular valve float within the atrioventricular septal defect. And then, as you all know, when we have such floating, there is the potential for shunting through the atrioventricular septal defect at both atrial and ventricular level. And when we have atrial and ventricular shunting, many of you still call this a so-called complete defect. We know, however, that the basic anatomy is the same when the bridging leaflets of the common atrioventricular valve are attached to each other and are also attached to the crest of the muscular ventricular septum. This is what many of you will call the partial defect. We can also call it the ostium primum defect. And when we have this arrangement, because the bridging leaflets are attached to the crest of the ventricular septum, shunting is available only at atrial level. And then, as we discussed in the classroom devoted to atrioventricular septal defect, we now know that rarely the bridging leaflets of the common valve in the setting of the common atrioventricular junction can be attached to the underside of the atrial septum. And then, of necessity, shunting through the atrioventricular septal defect will exclusively be at ventricular level. And this is the true atrioventricular septal defect of so-called VSD type with a trifoliate left atrioventricular valve. Now let's see how we can relate that to common arterial trunk. I'm going to show you this picture again. It's a long axis cut through a heart from an individual who has common arterial trunk. And here is a drawing of the same thing that's made by Diane Spicer. And I'm very much dependent on Diane for the concepts that I'm now going to put before you. Because if we compare these two images, what we have seen already is that the feature of the common arterial trunk is the commonality of the ventriculo-arterial junction. But then in comparison to what we saw with common atrioventricular junction, here with common ventriculo-arterial junction, we have an extensive defect. And I'd like to suggest to you that we can consider that defect as a ventriculo-arterial septal defect. And then again, what I'd now like to suggest, based on information that's become available through one of Diane's exquisite hearts, is that shunting across this ventriculo-arterial septal defect depends on the level of the leaflets of the common truncal valve. So let me make an analogy again to what we were looking at just a moment ago with atrioventricular septal defect. And let me show you three arrangements in which we have a common ventriculo-arterial junction. And let's look what determines the shunting through the septal defect. To your left hand, you are seeing the situation which we usually find. And this is common arterial trunk with a common truncal valve. And then we have shunting at ventricular level. Almost all of you will be calling this the ventricular septal defect. But you also have a gap of septation on the arterial side of the valvar leaflets. So potentially here we have the possibility for shunting at both ventricular and arterial level. Now in the middle, I'm showing you the arrangement in which septation has been complete at both the arterial level and the level of the arterial roots, but still we have a common ventriculo-arterial junction. Now, shunting will only be possible at ventricular level, and this in fact is the so-called juxta-arterial ventricular septal defect, the doubly committed defect, if you will. Some may even still think of this as the supracrystal defect. What I'm going to show you is the phenotypic arrangement of this defect is directly comparable to what we see in common arterial trunk. But I'm also going to share with you the evidence that has become available from one of Diane's very elegant hearts, and this fits very nicely with an arrangement we recently described of surgical experience with this variant. Because this is what happens when the leaflets of the truncal valve fuse with each other to produce dual orifices within the common ventriculo-arterial junction, leaving us shunting at arterial level, but an intact ventricular septum. So, it is rarely the case, but on occasion, the ventricular septum can be intact in the setting of a common ventriculo-arterial junction. And that leaves us persistence of the arterial component of the ventriculo-arterial septal defect. We can also, in fact, have an intact septum when the trunk arises exclusively from the right ventricle and the initial septal defect closes spontaneously. But what I'm going to be showing you is persistence of the arterial component of the ventriculo-arterial septal defect, and I'm going to compare that with the typical defect we see in the setting of common arterial trunk. I'm going to show you that that is a juxta-arterial defect. It can have a muscular posterior inferior rim, or it can be perimembranous. What I'm going to show you is that that is key to understanding the vulnerability of the conduction axis during surgical correction. Then I'm going to compare that with the situation where we have separation of the arterial roots, but still with an interventricular communication, and this is the juxta-arterial ventricular septal defect. Now, this is the case with which I was involved with quite some time ago, 5 years ago, with a group working in India. We published this in the World Journal of pediatric congenital heart surgery, and we showed that in this particular heart with a common ventricular-arterial junction, there was a tongue of tissue that joined together two of the leaflets of the common truncal valve. And that produced dual orifices within the common ventriculo-arterial junction. Diane Spicer has now found a heart that is virtually identical to the case that we came across at surgery. And this now emphasizes the importance of approaching the defect we see as a ventriculo-arterial septal defect. So this is the external view of the heart that's being processed by Diane Spicer. All of these are her superb images. There you will appreciate the common arterial trunk. It divides into an aortic component, and then we have a hypoplastic aortic arch. There is also a large pulmonary component, and the pulmonary component continues as a large arterial duct that then feeds the descending aorta. But this is the interesting component of this particular heart. Here you see that Diane has opened the common arterial trunk, and we're now looking down on the common ventriculo-arterial junction. And just as in the heart that was described in the surgical procedure by Garg and colleagues, there is a tongue of tissue that joins together two of the leaflets of this common truncal valve. And that has divided the common ventriculo-arterial junction into a right ventricular orifice and a left ventricular orifice. We have separate orifices within the common ventriculo-arterial junction. And this is what it looks like when Diane opened the right ventricular orifice. There you see on the septal surface the septal marginal trabeculation, or the septal band, and there you see the bridging tongue of tissue between the two leaflets of the truncal valve, dividing it into the right and left ventricular orifices. And there behind the bridging tongue is the orifice coming out of the left ventricle. Note that the caudal limb of the septomarginal trabeculation in this heart is fused with the ventriculo-infundibular fold, producing a muscular posterior inferior rim, and that will protect the conduction axis. This is the view that Diane has taken looking out of the left ventricle, and you can see the left half of that common truncal valve. There it is, the left ventricular orifice. But here is the lovely view she's taken from the right ventricular side again, showing you the bridging tongue, and then a raphe beneath the bridging tongue, who's attaching the leaflets of the truncal valve to the crest of the muscular ventricular septum, taking away any potential for ventricular shunting. So, what we've shown you there is that with dual orifices within the common truncal valve, there can be essentially an intact ventricular septum, but still with a deficiency at our arterial level. We also found, in fact, a further variation on this quite some time ago when I was working at Great Ormond Street. And here we published the case from Great Ormond Street as long ago as 2008, in which again there was that bridging tongue of tissue, but in this case the raphe was floating, so that there was shunting obvious in the setting of this case with dual orifices, one for the right ventricle, one for the left ventricle, within common truncal valve, but both arterial and ventricular shunting. These variants, however, are very, very rare, and almost always, when you have common ventriculo-arterial orifice, you will simply be describing the channel between the ventricles as the ventricular septal defect. But what I hope I've shown you is that that ventricular septal defect is part of a more extensive septal deficiency a ventriculo-arterial septal deficiency, and we can analyze it as we do the atrioventricular septal defect in the setting of common atrioventricular junction. But now let's come back and let's concentrate on what we have with the common ventriculo-arterial junction, because this is the typical defect you see in the setting of common arterial trunk. And for sure, you're going to continue to call that the ventricular septal defect. But do remember, it is part of this more extensive ventriculo-arterial defect. And I'm showing you now here the two variants of the ventricular septal defect in the setting of common arterial trunk. In both of these, the defect is opening between the limbs of the septomarginal trabeculation, or the septal band. It is an outlet defect. It has to be, because there has been no division of the outflow tract. To your left hand, you see the situation in which the ventriculo-infundibular fold is fusing with the caudal limb of the septomarginal trabeculation. And as we have seen in tetralogy, as we've seen in double outlet right ventricle, as we've seen in transposition, and we have this muscular posterior-inferior rim, then the muscular bundle protects the atrioventricular conduction axis. To your right hand, you see the variant in which the ventriculo-infundibular fold stops short of the caudal limb of the septal band. And then, when the defect is perimembranous, the conduction axis is at risk postero-inferiorly. Now here is the juxta-arterial and doubly committed isolated ventricular septal defect. And what I hope you can see is that it is more or less identical to the interventricular communication I showed you just a moment ago in common arterial trunk. There it is, directly juxta-arterial, but now with common ventriculo-arterial junction separated such that we have both a pulmonary valve and an aortic valve with a raphe between them, giving us the phenotypic feature of the juxta-arterial defect, which is an outlet defect. The phenotypic feature, fibrous continuity between the leaflets of the pulmonary and the arterial valves. And most usually, as you know, in these defects, there is a muscular posterior-inferior rim, and that protects the atrioventricular conduction axis. How do we know that this is part and parcel of the lesions found with common ventriculo-arterial junction? We know that because we have found this variant also in the mice in which we perturbed the furin enzyme. And we were able to show in these mice, as you see here, that the aortopulmonary septum has fused with the distal part of the cushions. The cushions themselves have separated the outflow tract into an aortic trunk, pulmonary trunk, but the proximal cushions have failed to separate the proximal outflow tracts, giving us and leaving us with the ventricular component of the ventriculo-arterial defect. Further evidence that what we are looking at here is a ventriculo-arterial defect, but with exclusively ventricular shunting. Now, you will then not be surprised to know that on occasion, this ventricular component of the ventriculo-arterial defect can be confluent with the ventricular component of an atrioventricular septal defect. And here is such a heart. You see that there is common arterial trunk, and you see that the trunk is arising exclusively from the right ventricle. So now we have a confluent defect which includes part of an atrioventricular septal defect. And then, because we have an atrioventricular septal defect, we have bridging leaflets of the common atrioventricular valve producing a trifoliate left atrioventricular valve, and we have the common truncal valve exclusively arising from the right ventricle. So atrioventricular septal defect coexisting with ventriculo-arterial arterial defect. So let's now move on and let's look at the other phenotypic variations. And one of these is the origin of the trunk from the ventricular mass. And usually this is balanced, but as I showed you just a moment ago, the trunk can arise exclusively from the right ventricle. On occasion, it can arise exclusively from the left ventricle. This is the typical arrangement. I've shown you this picture before, the long axis cut through the heart. There you see the crest of the muscular ventricular septum. And as you all know, usually the trunk is balanced. But when the trunk arises exclusively from the right ventricle, as you see here, in the setting of a completely muscular truncal infundibulum, the only way that the blood gets out of the left ventricle is through the interventricular communication. And that can be restrictive. If the surgeon wishes to correct this, then the aortic component of the trunk has to be passed through this septal defect to the left ventricle, so it may be necessary to enlarge the defect. If that is to be done safely, then we must remember that the conduction axis will be found posterior-inferiorly and will be at greatest risk when the defect, as in this specimen, is perimembranous. So the area that can be resected is the anterocephalad limb of the septomarginal trabeculation, remembering that on occasion within that part, we might find the first septal perforating artery. If the defect has to be enlarged, it might be a price to pay to jeopardize the septal perforating artery so as to provide a confluent channel from the left ventricle into the aortic component of the common arterial trunk. So what about the truncal root itself? In most instances, the truncal root is trisinuate. It has 3 sinuses. It has 3 valvar leaflets. It can also be quadrisinuate with 4 leaflets. And indeed, that is what we might expect by the undivided trunk. It can also be bisinuate, and the leaflets themselves can be dysplastic. So let's move on to perhaps the most important variation in the phenotypic arrangement. And that is the arrangement of the systemic and pulmonary arterial pathways. Now, there are at least 2 ways of describing these arrangements in alphanumeric fashion. I don't particularly like that, not least because the numbers and the letters themselves differ between the 2 systems. So we now prefer to describe what's going on by taking this notion of aortic as opposed to pulmonary dominance. And it's my good friend and colleague Richard van Praag who, a long time ago, in 1966, in one of his first papers on this entity, suggested that this lesion could indeed be described in terms of aortic as opposed to pulmonary dominance. So here, more of Diane's lovely pictures. Here you see the commonest arrangement in which the common arterial trunk gives rise to a dominant aortic segment. In this particular instance, the pulmonary segment is arising from the anterior part of the trunk and is showing crossing of the pulmonary arteries. Usually, the pulmonary segment arises a little more posteriorly. So this is the other variant. I've already shown you an example of this in a perturbed mouse. Here it is the pulmonary component of the trunk that is dominant. It gives rise to either side, the right and left pulmonary arteries, and then the dominant pulmonary segment continues as the arterial duct and supplies the descending aorta. And in this instance, there is interruption of the aortic arch, retroesophageal origin of the right subclavian artery, so that the ascending aortic component of the trunk is hypoplastic. And there is the part of the arch that should have been present, but now is interrupted. So we also need to take note of the particular arrangement of the pulmonary arteries. and this is most important when we have aortic dominance. Most usually they arise leftward and posteriorly, often directly adjacent to one another. And this is the problem with the numeric approach to classification, because typically this is neither type 1 nor type 2, and many might call this type 1.5. I've shown you an example where the pulmonary arteries can arise more anteriorly, taking the crossed origin. On occasion, they can arise directly from a truncal valvar sinus. The pulmonary arteries can also be discontinuous. One of the variants that is emphasized in the alphanumeric classification favored by Dr. Van Praagh. And then one of the pulmonary arteries is fed through the arterial duct. I've mentioned the aortic arch. It's right-sided in about 1/3 patients, and we should anticipate interruption or coarctation of the arch whenever there is pulmonary dominance. And that brings into play the arterial duct, because the arterial duct is part of an obligate circulation. We find it in pulmonary dominance when it feeds the descending aorta. We find it in aortic dominance when it feeds a discontinuous pulmonary artery. And it is rare to find the arterial duct, but it can exist when we have balanced aortic and pulmonary pathways. And that is what you see here. The aortic component of the trunk is more or less the same size as the pulmonary component of the trunk. And here we have persistence of the arterial duct. But that is unusual unless it is part of an obligate circulation. The coronary arteries are important. There is no distinctive pattern, but frequently they take an origin above the sinotubular junction. And that can be particularly problematic for the surgeon when the origin of the pulmonary arteries is close to the origin of the coronary arteries, as you see here. There is the origin of the left coronary artery. It is very close to that commissure of the truncal valve. And in this instance, the pulmonary arteries are arising within the sinus of Valsalva, giving rise to that left coronary artery. Note again, in this instance, the ventricular component of the defect is perimembranous. The conduction axis would be at risk postero-inferiorly. So let me finish by emphasizing the differential diagnosis. There are other lesions that might appear as common arterial trunk. Here I've listed them: a solitary trunk, aortopulmonary window, aortic origin of one pulmonary artery. Why do we call some instances solitary arterial trunk? What is the difference between a solitary trunk and a common trunk? And the difference is the absence of the intrapericardial pulmonary arteries. Because on occasion, those intrapericardial pulmonary arteries can be atretic, and they can still arise from a common arterial trunk. So the solitary arterial trunk is the name we give when we have complete absence of the intrapericardial pulmonary arteries, although to all intents and purposes, the trunk itself then is functioning as an aorta, and we see this typically in tetralogy with pulmonary atresia. The differentiating feature of the aortopulmonary window, which in fact is a common distal arterial pathway, is the separate origin of the aortic and pulmonary roots. And that is no more than persistence of the embryonic aortopulmonary foramen. But now we do need to differentiate that from the very rare finding I've shown you, persistence of the arterial component of that ventriculo-arterial defect. So this is the embryonic aortopulmonary foramen, and that is what we see when we have an aortopulmonary window, because in this setting, the arterial roots themselves and the ventricular outflow tracts have separated one from the other. Aortic origin of the right pulmonary artery exists when the left pulmonary artery arises from the right ventricle via the subpulmonary infundibulum. Please do not call this a hemitruncus, because this heart also has separate arterial roots and does not have the phenotypic feature of common arterial trunk, which is, of course, the commonality of the ventriculo-arterial junction. So what I hope I've shown you is that it is the commonality of that junction that is the essence of common arterial trunk. I hope I've also shown you the juxta-arterial isolated ventricular septal defect is closely linked to the common trunk in terms of morphogenesis, because the juxta-arterial ventricular defect is no more than the ventricular component of the ventriculo-arterial defect that we find with common ventriculo-arterial junction. We need to distinguish it from the solitary trunk, the autopulmonary window, and from aortic origin of the right pulmonary arteries. But once we've made the diagnosis on the basis of the commonality of the ventriculo-arterial junction, then I hope you will agree we can now best categorize the lesions in terms of pulmonary as opposed to aortic dominance, with paying particular attention to the origins of the pulmonary and systemic arteries. But again, the bottom line, phenotypic feature, is the common ventriculo-arterial junction.
Thank you, Bob. I have the privilege to record your voice. So that's amazing. We welcome Cecilia Brixton from Mexico City. Professor Anderson wants to know which hospital you work.
Oh, thank you very much. I'm in Monterrey. Actually, it's a city in the north part in Hospital Zambrano. Thank you very much. And thank you, Dr. Anderson. Sorry.
We miss Bob. We have some people that probably wants to intervene live. Hello, tutor. Vinci Matthew. Guillermo Lopez. So Bob, my first question, yesterday we have, you remember the cardiac surgery big webinar, and there was a lecture on truncus. And Dr. Dudechem underlined a bit that as a surgeon, we are looking not too much to the status of the coronary arteries in truncus. And but we realize, and he realized in his experience, that there is several problems with the origin of the ostium, obstruction, or sort of intramural course. Can you have some advice, or can you add something about this point?
Well, I think what I showed you is that you need to know where they're coming from. I think this is particularly the case when the illustration I showed where the pulmonary arteries take origin within a truncal valvar sinus. Because if the pulmonary arteries are arising within a truncal valvar sinus, then for sure, probably the left coronary artery is going to be very closely related to the pulmonary arteries themselves. So if you are unaware of that as surgeons, it's very easy for you to damage the coronary artery as you resect the pulmonary artery as part of the procedure, then to reattach that to the right ventricle. There is no given pattern of the coronary arteries in common arterial trunk. It's markedly variable. It is said that they don't arise from the pulmonary component of the trunk, but that's not strictly true. I think that high origin is also particularly common, and that again puts the coronary arteries very close to the potential origin of the pulmonary arteries, even then if the pulmonary arteries aren't arising from a truncal valvar sinus. Yeah. So I would say that the variability in the origin of the coronary arteries in the setting of common arterial trunk is particularly important, and is certainly something that you as surgeons should be paying attention to. I would say it's a mistake to say that the coronary arteries don't matter. I'm sure Eve wasn't saying that they didn't matter. I think they particularly do matter, and it's something that the pediatric cardiologist should be looking for and should be giving the surgeon that information prior to going into the operating room.
Yes. So we have Guillermo. Hi, Guillermo. How are you?
Hi, good morning. Hi, how are you? Dr. Anderson, good
Can you
morning.
introduce yourself? Which country where you work, please?
Yes, I am working in the Procape Hospital in the northeast of Pernambuco, Brazil.
Ah,
How are you, Dr. Anderson?
I'm
Very
good,
nice to
thank
see
you.
you.
Nice to have you with us.
Thank you, Doctor. I have actually
Good
have
about.
3 questions, but the first one is it possible that the truncus arteriosus would have its origin in the persistence of the 5th aortic arc, given that this event can cause different pathways like systemic to systemic, systemic to pulmonary, or pulmonary to systemic entities?
It's absolutely impossible because there is no such thing as a 5th aortic arch. I have described myself the presence of a 5th aortic arch, but I now know there is a paper published recently by a colleague of mine working in the United Kingdom called Anthony Graham. And Anthony Graham is an expert on development of the pharyngeal arch arteries, and never in either murine or human development do you see a 5th aortic arch. So there is no way that a common arterial trunk can have anything to do with a 5th arch, because the 5th arch does not exist.
Okay.
So we can get rid of that one straight away.
Sure. Yeah, you
So
explained it the other day, but this question came to my mind.
No. The first one is no. Go with the second one.
The second question is, what would be the key signal to arrange the formation of a common trunk to match with a common ventricular arterial valve, given that both processes follow their own way differentially to finally fuse each other?
I don't think that is strictly true either, because I think that the separation of the arterial roots can take place independently of the septation of the arterial component, the septation of the ventricular component. And we described a case, that was the case I described with Sang when I was at Great Ormond Street. He found the case where there was a common ventricular arterial junction. The common truncal valve was itself divided into separate components for the right and left ventricles, and yet there was still an arterial septal defect and there was a ventricular septal defect. And that is why today I was emphasizing the notion of a ventricular arterial defect that can be divided at arterial level, can be divided at ventricular level, or indeed in the typical common arterial trunk is open at both arterial and ventricular levels, with the leaflets of the truncal valve in between the two.
Thank you, Doctor. And just the last question. Does the failure of the development of the ventral protrusion of the dorsal wall of the aortic sac an essential factor in the development of this truncus arteriosus?
It is one of the variables. Typically, as you well know, in most frequently in the setting of common arterial trunk, the right and left pulmonary arteries take origin at the margins of the pericardial cavity. Sasha will know that very well as a surgeon. When the surgeon goes in, there is no separation within the pericardial cavity, and that is when the protrusion has not grown at all. So there's no separation between the aortic and the pulmonary component. That's what we call now aortic dominance. When you have pulmonary dominance, however, then the aortic component is hypoplastic and there is septation within the pericardial cavity. And that represents growth of that ventral protrusion, the so-called aortopulmonary septum. And that is why, if we're going to call it persistence of anything, it's persistence of the conus rather than persistence of the truncus. That's another reason by truncus is a terrible name for this entity. Common arterial trunk is good because that is what it is, but it is not persistent truncus arteriosus. The intrapericardial components of the trunk can be very well separated still with the common ventricular arterial junction. It is failure of the cushions or ridges to fuse in the intermediate and proximal part of the outflow tract that gives us the common arterial trunk.
Dr. Anderson, and there is a lot of questions about hemitruncus and common truncus arteriosus. So do we still have to use that term?
Hemitruncus should be totally banned because the one thing it is not is half a common arterial trunk. Again, I mentioned this at the end of my talk. The phenotypic feature of the common arterial trunk is the common ventricular arterial junction. In so-called hemitruncus, you have an infundibulum coming out of the right ventricle, which supplies the left pulmonary artery. Almost always, it's the left pulmonary artery with aortic origin of the right pulmonary artery. I have seen 1 or 2 cases with direct aortic origin of the left pulmonary artery, but that's very much rarer. So what we call, what many people call hemitruncus should really be called intrapericardial origin of the right pulmonary artery. In fact, it arises at the margins of the pericardial cavity again, and that is the distinction between an arterial duct, which is always extrapericardial. And indeed, when you have discontinuous pulmonary arteries with common arterial trunk, which is the Van Prague pattern, I think, A4, I think, is what he calls that. When there is discontinuous pulmonary arteries and the left pulmonary artery then is fed through an arterial duct, but there is then a common ventricular arterial junction.
Thank you so much. And here is a very good question about, is from Alan McGee. And he said, what about the association between common truncus arteriosus and complete tracheal rings? Have you seen those associations?
That's a very good question. And I don't know, Alan probably knows the answer to that himself. Typically, we see complete tracheal rings when you have the so-called pulmonary sling. I am unaware of any association between common arterial trunk and complete tracheal rings, but that might be ignorance on my part. If Alan is, maybe Alan, does he know of an association? Ask him if he can give us the answer.
Yes.
Actually, yeah, he said he had like 2 cases, and maybe he can share with us if he's live here.
I mean, I must admit I've never looked for common tracheal rings. I'm not sure I would recognize them if they were in front of me. Oftentimes the trachea is not present. I don't know whether, is Diane Spicer with us? Diane might be able to answer that. She said she was going to try and watch the presentation today.
No, Diane is not with us, but we have...
There's Alan. Alan, tell us what's going on.
You have to open microphone.
Unmute. You have to unmute yourself.
Unmute, okay.
There you go.
Essentially, I've seen a lot of patients in Uganda. For some reason, I don't know why, maybe ascertainment, there's a very high incidence of common arterial trunk there. And 2 patients were accepted for surgery and then were found to have complete tracheal rings, which made things very difficult, as you can imagine. And that was the only reason I brought this up. I don't think there's any way I can really think of an association, but just because of the big numbers of patients from there, I guess by chance this has arisen.
Have you written that up?
No.
You should do, because I think it's a very good question. As I say, it's not something I've ever looked for. And unless you bring that to attention, we're never going to know whether there's an association. You should write that up.
Okay, thank you. Nice talk.
See you.
You too.
Bob, there is Patricia Oliveira, she's a cardiac surgeon from Brazil, probably is here now. Patricia, we saw you. Can you open your video? She wrote in the chat, Bob, would you please let Professor Anderson that I love him a lot?
Ah, thank you. Thank
But
you. Very
now,
nice from Brazilian girls.
yes, she's with us, but we are not able. We saw her one moment, but now she's mute herself. There is some other questions, Cecilia.
Maybe she's embarrassed now. Isto está uma bagunza.
Cecilia.
I think there is another question about the selection of coronary ostium chosen in the correction of surgery, right? The selection of the coronary sinus.
What about it? What's the question?
Let me see here. How selective coronary ostia chosen by selective sinus in common arterial trunk? That's the question.
I don't quite understand.
Yeah.
There's no particular association with, that's one of the variations, that the coronary arteries can arise from any of the sinuses. That's another of the problems. I mean, it's not as if you can go into common arterial trunk and expect a given pattern. I think you have to diagnose each one on its merits.
No, I think that the question is more surgical because it's probably something about coronary perfusion during the procedure. So he's asking if yes, of course, they can use selective perfusion during the operation.
Right. Well, thank you for that.
Yes. And there is Miguel Arizapana that probably already asked about the 50th aortic arch. No, he asked about the persistence of the fifth aortic arch and interrupted arch with the common arterial trunk.
As I say, there is no fifth aortic arch, even though I have described it myself on several occasions. I am now mounting a campaign to do away with the fifth aortic arch. We initially thought we had seen one embryo in which there could have been a fifth aortic arch. It was a human embryo, but we now think that that is better described as a collateral channel. So all of the lesions that are described on the basis of the so-called fifth aortic arch, I now believe are better explained on the basis of either remodeling of the aortic sac. The aortic sac is the manifold contained within the pharyngeal mesenchyme, and that remodels into its horns, and it can do that in various fashion, or else it's explained on the basis of collateral channels, and it's collateral channels that explains double-barreled aorta. It's the presence of collateral channels that can explain the so-called duct-like entities that previously have been described as fifth aortic arches, but there is no fifth pharyngeal segment of mesenchyme, and never in any mammalian development, there has never been description of a fifth segment of pharyngeal mesenchyme.
Perfect.
So we should do away with the fifth arch. I know pediatric cardiologists love it, but we have to do away with the fifth arch.
So we destroy today the fifth arch.
Indeed.
And Hemitrancus doesn't exist.
Doesn't exist, do away with.
So we thank
good progress.
Yes, we thank Alan also for this additional support for new cases. Cecilia from Mexico.
And Alan in particular. Alan, you must describe those cases. It's very important.
I also appreciate you getting rid of the type 4 trunk, because I've always hated that.
Oh, that's another one. Absolutely. We can get rid of that as well.
Yeah.
We can get rid of truncus. We'll call it common arterial trunk, as you did. Nice one.
So, Bob, thank you very much. You will introduce the next week meeting with next week classroom, and we will see you next week.
And next week we start, do we not, on the functionally univentricular heart. So we are going to start a series of 5 classrooms, which we will explore the functionally univentricular heart. I also note that we're going to have our first Spanish classroom. And in fact, in the Spanish classroom, which will be devoted to pulmonary atresia with intact ventricular septum, my very good friend and colleague Vera Aiello is going to be talking about the morphology of pulmonary atresia with intact ventricular septum. Of course, that can be one of the forms of functionally univentricular heart. So I hope I'll be able to reinforce what Vera is going to tell you, because I will then subsequently be talking about that, but we will have 5 sessions concentrating on the functionally univentricular heart. So we look forward to seeing you all next week, and thanks to everybody for your attention this week. Thanks for your comments, Alan, very important.
Thank you. Thanks, Bob.
Thank you.
Bye.
Thank you very much.
Ciao.
Bye, Cecilia.
Bye,
Thank you very much.
Santa.
Bye, Bob. We'll
Bye,
see you
Dr.
on Tuesday, Bob. Hi, Cecilia.